Hello, this is John Kanalopoulos from our center here in Athens, Greece, the LaserVision Ambulatory Surgery Center, Clinical Professional Ophthalmology at NYU Medical School in New York City, New York. This is our surgery day today. This is a lady that we did in 2012, the first eye, high myo. Believe it or not, it took her 12 years to come in. She has mild keratoconus, and our calculation points out for a T5 lens. Our classic 135 incision. The novelty here is that I moved from the Alcon toric aspheric to the Clarion toric aspheric by Alcon hydrodissection. You can see here that the phaco is quite laborious, but I used 2 tubes of Viscoat, which is our magic solution, to be kind to the corneal endothelium, which, by the way, here was compromised in this lady. She had under 2,000 cells per millimeter square without having Fuchs. Here I'm filling in some more Viscoat, divide and conquer. I'm the first quad, and then second quad, and of course refill with Viscoat for 2 reasons. First, this lady being very high myopic, she has a huge capsular bag, and since the lens is quite tough, I'm afraid for a fragment to go and rupture the posterior capsule. I think this is number 4, Viscoat. So proof to the pudding, our cataract is out, quite laborious. This is ×8 in speed. I'm not as fast as it looks. And I think we're just over 200 joules, which is remarkable considering the density of the cataract. She was hand motion, best corrected vision. And of course, I'm taking care to remove all cortex with my split, fill with methylcellulose, polished posterior capsule, and here's our Clarion lens. Same cartridge, different injector. The fantastic unfolding that we're used to from the Alcon lenses. Remove the viscoelastic from under the lens, over the lens, and then go in and bring the dots of the lens to align with our marking and correct astigmatism. And this is the energy, just a little bit over 200 joules. Brilliant case, regardless of the density of the lens. Again, the Clarion lens, we're doing the dominant eye, left eye of this lady, much younger in age, less cataract, same philosophy here, toric lens, a T2 here, manual capsulorhexis. We've tried the femto, went back to manual. As you can see, better control and better resilience of the capsulotomy edges to the manipulations. We'll split in half and do halves here on this left dominant eye with approved to have less cataract. Again, I'm refilling with Viscoat, regardless of the younger age of this patient. She's 62, and the fact that the lens is much softer. You cannot be careful enough with endothelium, very careful. Irrigation aspiration. I'm going by manual here. I'm using the same probe to irrigate with my right hand and the aspirating probe through the paracentesis with my left hand. Fill the capsular sac with methylcellulose, Clarion lens, the cartridge, the Clarion injector, and we're going in again. A very nice, smooth unfolding of the Alcon lenses. I'm already a big fan of the Clarion lens. We remove viscoelastic from under the lens, over the lens, and now line up the lens. And here we go. Dominant eye aiming for better distance, and the non-dominant eye we're going to work with the Rayner hyper-prolate lens by Dr. Barrett. I'm looking forward to visiting Australia for the first time this year and hope to meet again Dr. Barrett from up close. The technique is the same, marking incisions at 135, a continuous curvilinear capsulorhexis, done manually. This is the right eye, non-dominant eye of this patient that was labeled in the past as being amblyopic. It is not. We had best corrected 20, 30 plus on this patient, but evidently we can see here that this eye has a denser cataract, nothing compared to the first case. And I'm going divide and conquer in 4 quads here, refilling with Viscoat. Cannot be careful enough. This is our secret for having patients first post-op day large number of patients for 2020, and if not, second or third day, because we're very cautious with the corneal endothelium. Irrigation aspiration, again, I'm going with my split left hand, but I'm retaining the irrigation on the right hand with a larger probe filled with methylcellulose. And now we're going to jump here and show you how this is a hydrophilic lens, so it comes into a casing with fluid, and this is the box of the EMV Rayner 1 called, we call it the Barrett hyper-prolate lens. So we click the preloaded lens and then fill with ProVisc, and this is footage from inside the room on how I'm going in through the same 275 incision, inserting the lens, and the lens unfolds very nicely. And here we're going to go back to my operating microscope view, click the lens, fill with ProVisc, advance the lens in the cartridge, and then again, same thing with a microscope view. Very nice, very controlled, smooth unfolding, lenses in position. I'm going to rotate it a little bit to get leverage with my Sinskey hook and go under the lens, remove viscoelastic over the lens, and then come and center the toricity. This lens had a diopter and a half astigmatism. I'm very happy with the result and the lens centration. This is John Canalopoulos signing out. Thanks so much for your attention.